Graves' disease, till now we are talking about this only. Graves' disease, it is an autoimmune disease. Females are more affected than males. So it is an autoimmune disease. So what happens is there are auto-antibodies against thyroid receptor. Auto-antibodies against thyroid receptor. TSH receptor antibodies. Okay. So this autoantibody, there is a thyroid gland. These receptors will act on. The receptor will act on the thyroid TSH receptors, and there will be increased production of T3 and T4. Okay, increased production of T3 and T4 because of activation of this thyroid receptor, TSH receptor antibodies. Okay, associated conditions like Addison's disease, myasthenia gravis, pernicious anemia, they are also associated with this autoimmune. It comes as a package. Everything will be there. What is Addison's disease? Addison's disease, heard, not heard? Am I visible? Audible? Everyone there?
Yes.
Yeah, what is the Addison's disease?
Adrenal insufficiency.
Adrenal insufficiency. Yeah. So Graves' disease, it is an autoimmune disease. Females are more common affected. Associated conditions are Addison's, myasthenia, and pernicious anemia. And in this disease, auto-antibodies are there against the thyroid receptor. These auto-antibodies are known as thyroid TSH receptor antibodies. TSH receptor antibodies. Okay. Is it clear?
Yes.
Why everybody is silent?
Yes, sir. Yes, sir.
Yeah.
Yes, sir.
And the other name for this is, long-acting thyroid stimulators, LATs. Long-acting thyroid stimulators. Okay. So normally what will happen, this is the gland, the thyroid stimulating hormone will stimulate it to secrete T3, T4 for a short period of time. But these TSH receptor antibodies, they stimulate it for a long period of time. So T3, T4 levels will keep on increasing. Okay.
Okay,
And
sir.
clinical features of hyperthyroidism, peritibial myxedema, thyroid acropathy, and eye signs. See here, features of hyperthyroidism, you know. Peritibial myxedema. This is a misnomer. Myxedema means, what is myxedema? Myxedema is hypothyroid, but it's a misnomer. Peritibial. There is edema in the peritibial region. That is a feature of hyperthyroidism only. And thyroid acropathy. There is swelling of the joints, small joints. That is thyroid acropathy. And eye signs are there. Von Graff's eye signs I did not discuss wantedly. So many eye signs are there. These are all the clinical features of Graves' disease. Management of Graves' disease. In children, drugs, propylthiouracil, methimazole, carbamazole, only drugs only. In pregnant lady, propylthiouracil. Okay, because it doesn't cross the placenta, P for P. It doesn't cross the placenta, so you have to give pregnancy, propylthiouracil. In adults without goiter, there is no swelling, only there is thyrotoxicosis. You have to give drugs followed by radioactive iodine ablation. Drugs and iodine ablation. Adult with goiter, drugs followed by surgery. There is a goiter, swelling also. So you just remove the swelling, you give surgery. Elderly patients, drugs followed by radioactive iodine ablation because they won't tolerate surgery. And eye signs may worsen during radioactive ablation. So if a patient has eye signs, you do total thyroidectomy. Okay. So this is just little confusing, but just to summarize, to make it in an easy way, most of the time it is only drugs. Okay. If the patient is tolerant to surgery, then you go for surgery. If he is not tolerant to surgery, then go for ablation. Drugs plus surgery or drugs plus ablation. Either one are the treatments. Clear? Yes?
1 second.
Yes, sir.
So hypothyroidism. Hypothyroidism, these are the features. You all know about these features. There will be dull, lethargic, bradycardia, constipation. The patient will have weight gain. and cold intolerance. Loss of appetite, but weight gain will be there. Cold intolerance, menorrhagia will be there. Okay. So T3 and D4 will decrease and TSH will increase. These are the features of hypothyroidism. So causes of hypothyroidism are iodine deficiency. Where is iodine deficiency more common? In which areas? In which geographical areas iodine deficiency is more common?
Mountains, hilly areas.
Yeah, subterraneans in mountains and all, because the washout will be there. It's just a logical explanation. And in Wolff-Chaikoff syndrome, this no need. Just an iodine deficiency, the most common cause of hypothyroidism. What is the treatment for this? Hypothyroidism treatment?
Levothyroxine.
Yeah, replacement therapy. You replace it. Okay, replacement therapy. Okay. And coming to important thing, Hashimoto's thyroiditis. It is also autoimmune. Most of the thyroid problems are autoimmune. Autoimmune problems are more common in females than males. It is associated with Down syndrome and Turner syndrome. Okay, these are the syndromes. And here, autoantibodies, same. In Graves' disease, autoantibodies are there against which receptor? In Graves' disease, autoantibodies are there against which receptor?
TSH.
TSH receptor. Very good. So here, autoantibodies are there against thyroid receptor, thyroid peroxidase enzyme, and thyroglobulin. Against these three, autoantibodies are there. Okay, thyroid receptor, thyroid peroxidase enzyme, and thyroglobulin. Okay, remember, those are thyroid stimulating hormone receptor autoantibodies, also known as LATs, long acting thyroid stimulators. Here, these are different: thyroid receptor, peroxidase enzyme, and thyroglobulin. Autoantibodies against this. Okay, and the classic picture is the gland is infiltrated by lymphocytes. Okay, the gland is infiltrated by lymphocytes. In morning breast cancer, I told you, if the breast tissue is having multiple lymphocytes, what cancer is it? What type of breast cancer is it?
Medullary.
Very good, excellent. So, what is the problem with Hashimoto's? Long-standing Hashimoto's will lead to lymphoma. That is the problem with this. Diagnosis: how to diagnose? You can just have the autoantibody levels. You can just have the autoantibody. Just take a blood sample and see that autoantibody levels. And management: you just give thyroxine. If diffuse goiter is there, you have to do surgery. Otherwise, replace with thyroxine. Is it clear? Hashimoto's, only one point is important in Hashimoto's: lymphocytic infiltration is seen. And the receptor antibodies you have to know. You have to know that there three receptors are there: thyroid receptor, thyroid peroxidase enzyme, and thyroglobulin, not thyroid stimulating hormone receptor. Okay.
Okay,
Yes,
sir.
no? Come on, give some response. If you want, I'll repeat
Yes,
it.
sir. Okay, sir.
What is lymphocytes?
What is lymphocytes?
Seen or what?
Sorry?
It's seen in the.
It is infiltrated. Thyroid gland is infiltrated with lymphocytes.
Okay, okay, sir.
Okay. Yeah. So in histopathology, you will see multiple lymphocytes in the thyroid gland. It is thyroiditis. Basically, it is inflammation of the thyroid. Okay. So it is due to lymphocytic infiltration. Why is it? Because of it is an autoimmune condition. Autoimmune condition, females are more common than males. That is the one point. So autoantibodies, body secretes antibodies which will act on the thyroid gland against these three things: receptors, enzymes, and globulins. Okay. So the patient will have a diffuse enlargement of the gland. So treatment, most of the times they present with hypothyroidism, features of hypothyroidism. Okay.
Okay, sir, okay.
Yeah. So simple. A patient comes to you. A patient comes to you with features of hypothyroidism. So first of all, you do a T3, T4, TSH. You know that T3, T4 are less and TSH is high. Then means the patient is having hypothyroidism. Then what you do is, you will just take a small, you will do an ultrasound and take a small FNAC. If FNAC is showing multiple lymphocytes, she is having Hashimoto's. Hashimoto's thyroiditis is confirmed. Then you do a blood level of antibodies. If antibodies are also confirmed, then you can send her for replacement therapy, thyroxine replacement therapy. Okay.
Okay.
So there are another two types of thyroiditis. Thyroiditis, that is decurvin viral or granulomatous thyroiditis. This is one, and Riedel's thyroiditis is the other. Okay. So this is viral infection. Viral infection is decurvin thyroiditis, viral infection. And Riedel's thyroiditis, the thyroid will be like woody thyroiditis, woody thyroiditis, wood. And a 45-year-old female was followed up with a physician for specific thyroiditis. She also has dupuytrenine contracture and prescription contains of steroids and tamoxifen. This is also Riedel's only. Riedel's thyroiditis will have dupuytrenine contracture. No need to go into details, but just for completion. Okay. Finally, we come to thyroid cancers. Okay. So concentrate here. Thyroid cancer is important again. Hashimoto's lymphocytic infiltration is seen in which thyroiditis?
Hashimoto's thyroiditis.
Woody thyroiditis is seen in which thyroiditis? Woody feel of thyroid.
Thyroid.
Viral thyroiditis is known also known as decurvin. Okay, that's okay. Then we'll come to thyroid cancer. What is the basic functional unit of thyroid? Like suppose, sorry?
Follicles.
Follicle, very good. See, the basic functional unit of kidney is?
Nephrons.
Breast is? It is a duct and lobule. Morning I discussed, right? It's a duct and a lobe. Duct and lobule. The same way it is follicle. Here it is follicle. So, some disturbance. Okay. So, differentiated thyroid malignancies may arise from follicle or parafollicular cells. Parafollicular cells. Okay. There is follicles. Multiple follicles are there. In between, there are parafollicular cells in the thyroid. So, either malignancy arises from follicle or parafollicular cells. What is if it is arising from follicle, it may be differentiated or it may be undifferentiated. Differentiated is having good prognosis. Undifferentiated will have bad prognosis. Indifferentiated again we have papillary thyroid cancer, follicular thyroid cancer. In undifferentiated we have anaplastic thyroid cancer. Can anybody tell me what is the parafollicular cells originating malignancy? Parafollicular cells originating malignancy.
Parafollicular.
No.
Parafollicular cell.
Medullary is medullary carcinoma.
Medullary thyroid cancer. Yeah. See, please listen here. I'll tell once again. This is very important so that everything we can finish it off. If you cut open the thyroid and send it for examination, see thyroid. If you see the cut section, thyroid is consisting of multiple follicles, and in between there are parafollicular cells. This is about follicle and parafollicles. So malignancy can come from either follicles or parafollicular cells. Follicular cells or parafollicular cells. In parafollicular cells, there is two types of malignancy. One is differentiated cancer. One is undifferentiated cancer. In differentiated cancer, we have two types: papillary thyroid cancer, follicular thyroid cancer. In undifferentiated, we have one type: anaplastic thyroid cancer. Cancer originating from parafollicular cells. In between these cells are there, right? Cancer originating from parafollicular cells is medullary thyroid cancer.
What is the disturbance behind?
Yeah, somebody, I think you have to switch off your mic. You got this point right?
Yes, sorry, just a moment again. So So cancers are two types of thyroid. So one is one which originates from the follicle cells, and the other is from the parafollicle cells.
Yes.
Follicles is divided into differentiated and undifferentiated.
Yes.
Among differentiated, it is
Papillary
papillary
and follicular
and,
cell.
Follicular.
follicular.
Yeah.
And undifferentiated is
Anaplastic.
anaplastic. Okay.
Yes.
Okay, got it.
And the cancer which is originating in this parafollicular cells is medullary thyroid. That's it. 4 cancers. Okay. And here the most common is papillary thyroid cancer. The most common is papillary thyroid cancer. This is the most common variety. Okay. Yes.
Yes, sir.
Yes, got it.
So papillary thyroid cancer. These are the important points. Papillary thyroid cancer. It is most common in iodine sufficient areas. Even if iodine is sufficient in that areas also, this is the most common thing. Papillary thyroid cancer. See, thyroid problem, females, anytime you can close your eyes and just mark it. Females are more common than males. Okay, more common affected than males. And age group also is the same, 3rd and 4th decade of life, little early only. It is not a malignancy of old age. 3rd to 4th decade of life. Risk factors, radiation exposure, long-standing thyroglobal cyst. Did this point, did you discuss this point? Yes, no?
Yes, sir.
Long-standing thyroglobal cyst will develop into papillary thyroid cancer. This point I discussed. And long-standing Hashimoto's thyroiditis will lead to, can somebody tell this? Sorry?
Lymphoma.
Very good, very good. Okay. So, very good. That's nice. So, genetics, most common gene is BRAF gene. It is not BRCA, it is BRAF. Okay, most common gene, not necessary. And diagnosis, just put in FNAC and you have 3 important. Just if you don't remember anything from this class, also is okay, but remember these 3 things. 1, Samoma bodies. 2, orphan ani nucleus. And 3, nuclear grooving. These are the 3 classical signs of FNAC of biopsy of papillary thyroid cancer. Okay, what are those? Samoma bodies. One is Samoma body. Second is orphan ani nuclei. I'll tell each of them. And third is nuclear grooving. So we'll see. See here on cut section on histology. This, what is this in between that yellow, that blue thing is there, right? That is a Samoma body. Samoma body. Okay. Samoma. Sure. Yes. If Samoma body
Yes,
is
sir.
seen, it is classic of which cancer? Papillary, follicular, medullary?
Papillary.
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 Samoma is
Papillary.
there. Papillary. Make it sure, because in the image they can give this image only. Direct image they may give you. And this is a cartoon character. Orphan ani. Orphan ani is a cartoon character. Orphan. Sorry. Orphan Annie is a cartoon character. And look at her eyes. Orphan Annie eye nucleus. See here. See here. This is classical description of papillary thyroid cancer. Orphan Annie eye nucleus. Okay. And the third is there will be grooving. If suppose this is the cell, this is the nucleus, there will be grooves in the nucleus. Nuclear grooving. Okay. These 3 are the classical signs of papillary thyroid cancer. Yeah. Can somebody just tell me what are the 3 classical signs of papillary thyroid cancer?
Samoma bodies, orphan ani nucleus, and nuclear grooving.
Yeah. Remember, on saying this, you should identify This is a subhomo body. Okay, just recollect this image, subhomo body. And on seeing this, you should tell whether the orphan nucleus, see here, okay, and there is grooving also, nuclear grooving. If these three are there, it is papillary thyroid cancer. So what is the treatment for thyroid cancer?
Surgery.
Yeah, which surgery?
Thyroidectomy,
So
radical.
total
Chemotherapy?
thyroidectomy.
Subtotal.
Total.
Chemithyroid, near total, subtotal, total.
Total.
Total thyroidectomy.
Total thyroidectomy. It is a malignancy. Okay, so there may be chance of recurrence if you leave something behind. So you have to remove the entire gland. Okay. So this is a little extra thing I'll tell in the last, but otherwise total thyroidectomy is the answer. And along with total thyroidectomy, we have to remove some lymph nodes also. Okay. Do you know the levels of lymph nodes in the neck? Yes, no?
No.
Okay.
No,
So
sir.
there are actually 7 levels of lymph nodes in the neck. Okay. They are arranged in 7 levels. Okay. So level 1 is this one, submandibular. Level 1 is submandibular. Okay. 2, 3 and 4 along the sternocleidomastoid. 2, 3 and 4. If you can see this image, see here carefully. Level 1, the submental and submandibular, the lymph nodes here. This is level 1, submental and submandibular. Level 2, 3 and 4 are lateral compartment. Upper jugular, mid jugular and lower jugular. Level 2, 3, 4. Okay? Clear?
Yes, sir.
Level 4 is the central compartment. Sorry, not level 4. This is level 4. Level 5 is the posterior compartment. Posterior. Level 6 is the central compartment. And level 7 is the mediastinal compartment. So there are almost 7 lymph nodes levels here. So whenever you do a total thyroidectomy, always you have to remove the level 6 lymph nodes.
So can you repeat once?
Sorry?
Can you repeat once more, sir?
Yeah. The levels I'll repeat once.
Sir, everything, sir.
Okay. So this still here it is okay?
Yes, sir.
Okay. So the treatment of thyroid cancer is thyroidectomy, total thyroidectomy. Along with total thyroidectomy, you have to remove some lymph nodes also. So which lymph nodes to remove is the level 6 lymph nodes. Only level 6 you have to remove. But to know what is level 6, we have to know that there are 7 compartment lymph nodes here in the neck, arranged in the neck. So what are the 7? One is the submental. Submental and submandibular is level 1. Level 2, 3 and 4 along the here the sternocleidomastoid muscle is there. Along the sternocleidomastoid, the lymph nodes are there. Those are level 2 upper, level 3 mid, level 4 is lower. 2, 3, 4 are over. Posterior triangle, that is behind the sternocleidomastoid, the lymph nodes are there. Those are 5, level group number 5. And central compartment is 6 here. This is submandibular 1. Here 6. This is 6. And mediastinum is 7. Okay? Is this okay?
Okay, sir.
Yes, sir.
Yeah.
Sir, in total thyroidectomy, we have to remove 6 lymph node, 6 level as well.
Yeah, in total thyroidectomy, along with that, we have to remove the level 6 only. Normally, level 6 and total thyroidectomy. That is the treatment option. Okay. And if any other nodes are there on imaging, we'll do a CT scan or ultrasound. If any other nodes are there, then you have to completely divide the entire region, 7 regions. Okay. So to make it simple, the surgery, if somebody asks what is the surgery for papillary thyroid cancer, so the option is total thyroidectomy plus level 6 dissection, or we call level 6 is known as central compartment, central node dissection. That's it. If there are other nodes visible, then total thyroidectomy and radical neck dissection. So we have to remove the entire lymph nodes from the neck. This is known as radical neck dissection, which includes almost 7. Everything 7 we have to remove it. Now it is clear?
Yes, sir, it's fine.
Yeah.
Sir.
Okay. So you have removed the thyroid gland. How will you follow up this patient? You should tell me, how will you follow up this patient? Follow up. You have done. So simply remember total thyroidectomy and level 6 clearance you have done. Okay. Total thyroidectomy and level 6 central compartment you have cleared. The patient is happy. Now he is not having cancer. So how will you follow up? Will you send the patient directly or will you give some medicines to him? Which medicines you will give?
Beta blockers.
Thyroxine?
Now no need of beta blockers. You have removed the thyroid. Beta blockers is given only for hyperthyroidism.
Yeah.
Now,
Thyroxine.
yes, somebody was telling. Yeah. You should give
Thyroxine.
thyroxine. Very good. Thyroxine replacement you'll give. Okay. And any other thing you'll check? Sometimes 6 months. Yeah, sorry.
Calcium supplementation?
Yeah, calcium you'll check. If it is less, you'll give calcium levels also. Okay, very good. Okay. And will you leave him like that or will you follow him for something else? This is a thyroid cancer. There is always a chance of
Metastasis.
Recurrence.
there is a chance of recurrence. Okay. There is a chance of recurrence. So after 1 year or after 6 months, depending upon the thyroxine levels and depending upon the grade of the disease, what you will do, you have to do a whole body iodine scan using iodine 123. Whole body iodine scan using iodine 123. Okay, you did a whole body iodine scan after 1 year and you find a small metastasis somewhere, then what you will do? Till now it's clear. You are giving thyroxine, you are following the patient. On follow-up, you did a whole body iodine scan. On iodine scan, there is a small metastasis. So what you will do in such cases?
Chemotherapy.
Ablation?
There no need of chemotherapy. Just
Did you do an ablation then?
ablation, radioactive ablation using iodine
131.
131. That's it. A small metastasis is there. No need to give chemo or no need to give radio or no need to give any surgery also. Just give iodine 131. It will get ablated. Okay. This is the way to follow up the patient. You have to give thyroxine, monitor T3, T4 and TSH levels continuously. You should give calcium if there is any doubt of decrease in calcium levels. And for recurrence sake, you have to do a whole body iodine scan. Okay. You do a whole body iodine scan. Iodine 123 is you give iodine 123 and you have to check whether there is any recurrence. If there is no recurrence, it's okay. If there is recurrence, you will do an radioactive iodine ablation. So see there, the whole body iodine scan is done. If residual disease is there or metastasis is there, radioactive ablation is done. Okay, this is what I want. Okay, before we go to the next slide, and everybody is telling, I'll give thyroxine. Okay. Yes, no? You will give thyroxine to the patient after thyroidectomy. Yes, no?
Yes.
Yes.
Okay. So you will give thyroxine. Supplemental dose. Or this is known as replacement. No, better term is replacement dose. Replacement dose. Suppose the patient's replacement requirement is 100 micrograms, 100 mcg. The patient is using 100 mcg. Okay, that is a replacement dose. Listen carefully. That is a replacement dose, 100 mcg. You will prescribe only 100 mcg. But no, I will prescribe 200 mcg. Double the dose. 200 mcg I will prescribe. And I will call it as suppressive dose. Suppressive dose. Why I am doing like this? Think and tell, even if it is wrong, nothing.
Depending on the half-life.
No.
The requirement after surgery, right?
Yes. See, again, I'll repeat the question. It is a very important concept to understand. I'll just tell you. See, a patient underwent thyroidectomy for cancer. Okay. So you calculated the replacement dose, supplement dose, replacement dose. Replacement dose comes around 100 mcg. Replacement dose is 100 mcg. If you give 100 mcg, that is enough for the patient. But I give a suppressive dose of 200 mcg. Why is it so? What is the reason behind? I am increasing the dose. I am increasing the dose and I am giving to this patient. Why?
Drug metabolism.
No, 100 is enough actually, but I am increasing the dose.
Excreting.
Prevent storm.
No,
To prevent
Okay.
storm.
no. Okay, so see here,
So is it
papillary thyroid.
because if there is any remnant left to suppress that? Is it?
Okay, yeah, it's partly correct. But see, papillary thyroid cancer. This is the thyroid gland. There is a cancer. The growth of this cancer depends upon TSH. Thyroid stimulating hormone should be there. Thyroid stimulating hormone. The name itself is telling. It is a stimulator. Thyroid stimulating hormone. Okay. So, if we give excess of thyroid, what will happen to TSH? It will increase or decrease. I am giving so much
Decrease.
thyroid.
Decrease.
Sorry,
Decrease.
it will decrease. It will decrease drastically. TSH will be almost no TSH will be there in the body because you are giving so much of thyroid. Excess suppressive. You are suppressing. The meaning of suppression here is I am suppressing the TSH. So indirectly, I am suppressing TSH so that TSH dependent cells are there, right? TSH dependent cancers, if it is there somewhere else, it is suppressed. Got my point?
Yes, sir.
Others
Yeah, got
also?
it. Yeah.
Yeah, everyone, is it clear? Everyone, is it clear?
Yeah, clear, sir.
Okay. Can somebody stress only this point? Why I am giving suppressive dose?
So, total thyroidectomy, the patient is requiring the replacement dose. He might be requiring only 100 mcg.
Yeah.
But we give 200 mcg, which is the suppressive dose, in order to suppress the thyroid stimulating hormone, so that if there is any other cells requiring thyroid stimulating hormone present, will also be suppressed.
Suppressed. Very good. Okay. And we have one more important, serum thyroglobulin is a marker, tumor marker. Okay. We will do this serum thyroglobulin. If it is increasing, it is a marker like PSA. I told you, prostate specific antigen. In the same way, serum thyroglobulin is a marker. It's a simple blood test. If we do this, we will come to know that whether there is any chance of recurrence. If it is increasing, then we will do that whole body iodine scan with iodine 123. Okay. So this is an important simple test. Okay. So serum thyroglobulin is an important marker for DTC. Okay. And PTC, remember, it has the best prognosis. PTC has the best prognosis. Second most common is follicular thyroid cancer. Second most common. It is most common in iodine deficient areas. Iodine sufficient areas, what is the most common?
Papillary.
Papillary thyroid cancer. Yeah. It is iodine deficient areas. It is follicular thyroid. Risk factors are long-standing multinodular goiter, no need of this, genetics mRNA, spread by hematogenous, presentation is by swelling. FNAC cannot differentiate follicular adenoma and carcinoma, you know that. Post-op and follow-up similar to PTC. Almost everything will be same. Thyroid replacement dose, suppressive dose, thyroglobulin, everything is same for both thyroid and parathyroid, follicular, thyroid, papillary and follicular, except the point that it is second most common and it is most common in iodine deficient areas. And FNAC is not enough here. FNAC will not differentiate adenoma and carcinoma. And coming to the last one, medullary thyroid cancer. Medullary thyroid cancer origin. What is the origin of this one? F or PF?
Parafollicular.
Parafollicular. Yes, it is not follicular. It is parafollicular. Okay. So this is parafollicular cells which secrete calcitonin. Okay. So they arise from ultimobrachial bodies of the neural crest. It is seen in MEN2 syndrome. What is MEN? What is this syndrome? MEN2 syndrome. Anybody?
autosomal dominant.
Multiple endocrine neoplasia.
Multiple.
Endocrine neoplasia.
Very good. It is a part of a syndrome called multiple endocrine neoplasia. Multiple tumors are there in the parathyroid, in the adrenal, in the pituitary. There are multiple tumors are there. Okay. So multiple endocrine neoplasia. It is a part of these tumors. Okay. So the patient will be having thyroid swelling. He will have diarrhea. See, if in the question, if diarrhea is there, flushing is there, lymphatic or hematogenous spread is there, in these conditions, they always go for medullary thyroid cancer. Option is medullary thyroid cancer. So see the question properly. If diarrhea is there, flushing is there, lymphatic or hematogenous spread is there, then you go and go for medullary thyroid cancer. Okay. Diagnosis again by FNAC here. Management is surgery. Okay. There is no role of iodine scan or radioactive iodine ablation in medullary thyroid. Only surgery here. There is no role. Can anybody tell me why there is no role? Whether PTC and FTC, like follicular and papillary, are both the same almost in treatment wise. But medullary thyroid is very much different. Why is it behaving so differently?
Maybe
it's
because
more
it
like
does not respond to radioactive iodine radiation.
Yeah, why? It is not originating from the follicles. Okay, that's the importance of the first slide. It's not originating, it is somewhere else. It is parafollicle. Okay, if it is follicular, it is iodine, it is resistant, it is reactive to iodine. It is somewhere else, so it is not reactive to iodine. So the surgery is total thyroidectomy with central node dissection. Same surgery is same, both total thyroidectomy and central node dissection. If thyroid plus level 6 lymph nodes are involved, then you have to go for modified radical neck dissection. And treatment for these are the newer drugs available recently: vandetanib and cabozantinib. Okay, these are the two molecular drugs available. Okay, for metastatic. They think there is there in your pharmacology also. Okay, so what is the tumor marker? What is the tumor marker for differentiated thyroid cancer? What is the tumor marker for differentiated thyroid cancer?
For papillary thyroid carcinoma.
What is this?
No, I am just asking you, what is the tumor marker for
Thyroglobulin?
Thyroglobulin, yeah. I am not asking specifically. Then go for thyroglobulin. Thyroglobulin. For papillary thyroid cancer?
Thyroglobulin.
Both. The same answer. And tumor marker for medullary thyroid cancer? Anybody? Tumor marker for medullary thyroid cancer? Sorry? It's in the first slide I showed you. It secrete. What does it secrete?
Calcitonin?
Secrete?
Calcitonin?
Yeah. So calcitonin is the calcitonin. Calcitonin. This is the important. This is an important question. Calcitonin is the tumor marker for medullary thyroid cancer. For differentiated papillary, it is thyroglobulin. For medullary, it is calcitonin. Remember. And last question I'll ask you. A patient is there, 40-year-old female with neck swelling. FNHA has shown thyroid malignancy. The patient is having diarrhea. What is the probable diagnosis?
Hypothyroidism.
Medullary
thyroid cancer.
Medullary thyroid cancer. Very good. So if the patient is having diarrhea, it is medullary thyroid cancer. So just that point is important, because thyroid and diarrhea, we think it is it is toxic and all. But no, if it is malignancy, it is medullary thyroid cancer will have diarrhea. Okay. So this is something about thyroid. We went extensively into the first. We have discussed some anatomical points. Then we discussed something about the clinical signs, the various manures, Pizillos, Lahes, Kryles, and then we discussed about hypothyroidisms. We discussed about various cancers, and two important subtopics like retrosternal goiter we discussed in detail, and hypoparathyroid, Chvostek's sign. What is Chvostek's sign?
Twitching of face muscle.
Yeah. What is Troche's sign?
Palpopedal spasm.
Yeah. And what is Pemberton sign.
Flushing of face when
Where
arms are
it is
lifted
seen,
up.
Pemberton's where it is seen.